Hi, I'm Dr. Brian Kaufman, a retired family doctor and a CLL patient myself, and the Chief Medical Officer, Executive Vice President, and co-founder of the nonprofit CLL Society. Dr. Woyach, can you introduce yourself, please?
Sure. I'm Jennifer Woyach. I lead the CLL group at The Ohio State University.
So Ohio State has done really important and breakthrough research in CLL. And one of the big areas that's going on in research now in CLL is not only what are the best therapies, but what are the best combinations of therapies. And there's been a lot of excitement at the major cancer and hematology meetings about combining this drug with that drug. And if one is good, maybe two is better, and maybe three is even better than that. You presented a really important paper at the American Society of Clinical Oncology. And can you describe what you were thinking about, why you wanted to do this research, and give us the details?
Absolutely. So this year at ASCO, I presented the preliminary initial results of the Alliance for Clinical Trials in Oncology A041702 trial. And this is a phase 3 study of the combination of Ibrutinib plus Venetoclax plus Obinutuzumab versus Ibrutinib plus Obinutuzumab in previously untreated patients who are age 65 or older. And so this is actually the successor study to the A041202 study, which compared Ibrutinib plus rituximab, and bendamustine plus rituximab in previously untreated older patients with CLL, showing that the Ibrutinib-containing regimens produce superior progression-free survival compared with chemoimmunotherapy in this age group.
And I'm going to just stop you there, because I think that in combination, and see if I've got this right, with the ECOG trial that looked at comparing Ibrutinib to FCR in a younger population group, I think those two trials were presented together at the same ASH meeting, and they both, I think, put two nails in the coffin of chemoimmunotherapy, hopefully, in CLL. Yes. They were game-changing, and thank you for your leadership on that. That was a really important piece. And I think we're finally starting to see, I know this is not what we're talking about, a shift in the community. The academic centers were already using targeted therapies, but I think we're finally starting to see that the use of chemoimmunotherapy is waning in the community, where 70+% of patients get their care. So thank you.
Oh, absolutely. Yes, I think that's been really exciting to see that shift from chemotherapy to targeted therapies. Now, of course, as you all know, over the past few years, we've seen the introduction of Venetoclax-based regimens with antibodies, either rituximab or obinutuzumab, in the frontline setting, and allowing then patients to receive targeted therapies that are given over a fixed duration rather than the continuous administration like we use with the BTK inhibitors, Ibrutinib, acalabrutinib, and zanubrutinib. So in this study, we wanted to, take the same patient population, so older patients, the majority of patients with CLL, and see whether we could add Venetoclax to the regimen of Ibrutinib plus Obinutuzumab, allow for a potential therapy discontinuation and long progression-free survival. So the way that we designed the study is everybody who was randomized to Ibrutinib plus Obinutuzumab, they received 6 months of Obinutuzumab, then indefinite Ibrutinib. The group that was receiving the triplet therapy would have their Ibrutinib plus Obinutuzumab the same, but we'd also add in Venetoclax for the first year. And then after a year, everybody would have a response evaluation, and this included an exam, labs on the blood, a bone marrow biopsy, and CT scans. And those patients who were assigned the triplet arm, if they had a complete response with undetectable minimal residual disease, they stopped all treatment. And if they didn't, they continued Ibrutinib indefinitely. So we were testing
Let me stop you there for a second. Was it undetectable measurable disease in the blood or marrow? Or
in both? The bone marrow.
The bone marrow, okay.
In the bone marrow by flow cytometry that was performed centrally.
Okay.
And so we were testing this kind of response adapted discontinuation versus the continuous Ibrutinib Obinutuzumab. And we have enrolled 465 patients to this study, and they were randomly assigned to one of those two groups. Unfortunately, we are actually presenting the results of the study at this meeting because we did hit a predefined futility boundary. And found that the
So
triplet.
explain to what a futility boundary is, because I'm sure most of the patients listening don't know what that means.
Right. So we always build into large studies some stopping rules so that you don't get to the end of a study in 5 years and realize you had done something that either was hurting patients or was not going to help them. And so the way that we do this is we put in interim analyses, and the interim analyses are usually done after a specific number of events, either progression events, deaths, things like that. And you look at both safety and efficacy. And so you have defined stopping boundaries for safety. So if the triplet was not as safe as the doublet, you might stop. Or in this case, if the triplet can't be more effective than the doublet, you stop. So we reached one of the interim analyses, again, performed after a certain number of patients progressed, and found that given the distribution of progressions from the triplet to the doublet, there was no way that the triplet is going to be better than the doublet in terms of progression-free survival. So when we look then at progression-free survival, and we have a very short follow-up, it's actually only about 14 months of follow-up, and about 30% of the patients actually have not yet gotten to the end of the first year of therapy. But we found that the progression-free survival actually was basically the same and trended to be a little bit better with the doublet than the triplet, which is really surprising. And especially surprising at this time point, because since most of the patients are still on therapy or just newly off therapy, based on previous data, we wouldn't expect that a lot of patients are going to progress at this time. So that means that these results are likely because people discontinued and had other events happen. So in addition to the progression-free survival, overall survival is basically the same between the two groups, again, trending a little bit towards favoring the doublet. Now, unfortunately, most of this study took place during the COVID pandemic. And when we looked, we actually had a relatively high number of patients, unfortunately, die of COVID in both arms. And it ends up being about 5% of the patients enrolled on the entire study died of COVID, which is, of course, a very high number. And these are older CLL patients, which we know were particularly at risk, especially during the first couple of years. So what we did, we don't want the takeaway to be that this triplet is not a good therapy because it was undertaken during the time of the COVID pandemic. So in addition to looking at the results for everybody enrolled on the trial, we actually censored all of the patients who died of COVID to see how that affected our progression results. And we found that there was an imbalance in death where there was more deaths in the triplet arm, so the I plus V plus O arm, compared with the doublet arm. And so when we censor the patients who died of COVID, still the progression-free survival is very similar, but now actually trends the other direction where the triplet looks a little bit more effective than the doublet. Same thing with overall survival. Now, because of the way the study is written and performed, the study, these are the final study results, and we have to say that the triplet is not better than the doublet. Luckily, we did have a lot of support from the companies that were providing the drug, the NCI, and even the FDA to say that, since the study was almost finished, and there did not seem to be, especially at this point in time, in this part of the pandemic, didn't seem to be a safety issue with the triplet arm, that we could continue the study as planned. So, we still will say that the study is a negative trial, but we will be allowed to continue the treatment of every patient on the trial as long as they want to continue to participate and continue to look at long-term data. Because, we think even though there may not be a difference in terms of the overall efficacy between the triplet and the doublet, there might be some benefits still to doing a more intensive treatment and allowing for discontinuation. One thing we saw that was actually really interesting is over 80% of the people on the triplet arm had undetected minimal residual disease in the bone marrow. So that's really high. Actually, that's higher than has been reported on any other study.
But that's impressive. But it's also interesting that it didn't translate to better progression-free survival.
Right. So I think that the problem still there is that almost all patients were still on Ibrutinib because they're still within the first year and a half of treatment. So I don't think, even when we were designing this study, we would have not expected any difference in progression-free survival right now, because almost nobody relapses on this type of regimen within a year and a half. I think if we actually are going to see some benefit to that regimen, you'd likely see it later on at 3 and 5 years, when maybe people who were on continuous Ibrutinib have come off because of toxicity or didn't want to continue taking the drug. And then you may find that people who got a deeper remission would do better.
So let me ask you this question, which seems obvious, is there was a disproportionate number of deaths in the triplet arm. Is there, Venetoclax has some suppression, low neutrophil counts are not unusual with it, and it can also suppress the healthy lymphocytes. And Ibrutinib can have mixed effects on the immune system. And Obinutuzumab, we know, lowers your immunity. Do you think it's that triplet that put people at higher risk than the doublet? Are there, what are you thinking as a physician scientist about that piece?
Right. I think it's going to be very difficult to really say for sure. We have looked at the neutrophil count, and that actually does not appear to be associated. So most of these deaths did not occur at a time of neutropenia. Interestingly, there were quite a few that actually occurred after the Venetoclax was complete too, and even in people who were off treatment. Now, we know that effects from this regimen likely, they don't go away the next day. So they do likely persist for a period of time. And we don't know exactly how long that is. So it could still be that there is some disadvantage to the immune suppression from Venetoclax that is causing this. It could be too, we know that CD20 antibodies are not great when people develop COVID. And maybe that the Venetoclax just kind of tips things over the edge. We also know, like you said, that there are kind of mixed benefits of Ibrutinib on the immune system, including some potential benefits of being on Ibrutinib. And so in the cases where the people were off therapy, did the Venetoclax have nothing to do with it, but is it because they weren't taking Ibrutinib anymore? I don't know. I think that, there are a lot of things that we still need to look more closely at, and maybe even be able to dive into in the laboratory to figure some of the mechanism out.
Well, I'm so glad you're doing this research, because we can't just assume if 2 is good, 3 is better. I mean, it's just so interesting. And even though this gives us an answer, as you say, it's only like a partial answer.
Yeah, and that's absolutely the case. And that's actually the reason, you mentioned the ECOG and Alliance studies from before. And actually, there are 2 studies going on right now. This study and the ECOG group also has the same sort of trial design, meaning the same arms, IO versus IVO for younger patients, that is still ongoing. And we may see different results because, they're 2 very different patient populations. And as you say, maybe 3 isn't better, especially for older patients. And maybe 3 will be better for younger patients. We just don't know.
And also, when you look at these, you're bringing up a point, as a patient, you've always got to say, well, that trial, am I one of those people in that trial? Would that fit for me? Do I match with who is being studied in that trial? Those are very important things for a patient to consider. Any final thoughts or anything you want to share with the CLL community about this trial or about future directions that this research is going?
Well, I just want to emphasize again that the study, while technically complete, will have long-term follow-up to it. So hopefully in the next few years, I'll be able to let you know what happens, 4 years down the line for people who do discontinue therapy, and we can see how well they do over time. As well, we're working right now to develop the next trial that the Alliance will run, hopefully again in older patients as a frontline therapy. This one will be led by Jennifer Brown and Danielle Brander, and we're really excited, hopefully, to launch that within the next year.
Well, Dr. Woyach, thank you for the research you and your team are doing, and the whole Alliance group is doing. This is it's really important to get these answers. Thanks so much.
Oh, thanks for taking the time to talk with me about it.
Great.